guys.
Hi, everybody. Welcome back to AI Live. I'm Lori Robertson, Gideon, Kwok. Regis and Kathy. This is our casual show that's kind of our give back that we like to do for free for the aesthetic community. So we have a lot of fun things going on, and tonight's topic is talking about occlusions and adverse events. I hate to say occlusions, but it's really vascular adverse events. And we have some terrific experienced injectors on with us. So we're just going to chit chat later on about what we've seen and how we've treated things and the assessments and what we need to know. So it'll be good stuff coming up.
Yeah. And it's even beyond occlusions, right? Because that's what is going to be our next webinar. I think it's next week or the following week.
The 13th of December.
Because it's, I think that it's important to not only, we obsess, I think, in the industry about occlusions, because that is the, I don't know, that is the, like, the hot topic for some reason.
Fear.
It's the fear. I think it's the fear factor. But, all the other potential things that we've actually had to deal with in our careers of all the different things, from lasers to blah, blah, blah. We can talk about all of our, not necessarily horror stories, but different things that have occurred, and hopefully we can shed some light on it. And you guys definitely get interactive. This is your time to ask questions to all of our panelists, and this is a cool time because it, and I think for us it's more just open-ended. We're not paid by anybody, so we can kind of talk and talk more freely than when we are on stage, it's a time to pick all of their brains, because we all have different patient populations. We've seen different things and we've experienced different things, but we have some housekeeping first.
We do Okay, so number one, super important, you guys, on December 12th through the 23rd, mark this in your calendars, we start the 12 Days of Aesthetics giveaway.
Yay.
So we love to do this. We've done this for the last few years. We have great products, services, you name it. We have amazing things that we are going to be giving away each day from the 12th to the 23rd. So follow us on Instagram at the Aesthetic Immersion.
Or on
and
YouTube.
Look at the rules, and you'll see all the rules in the post to kind of see what you need to do to join and to get into that raffle.
Yep. Yeah. What else? Beyond Occlusions, our live stream event, that is going to be December 13th, and that's at 10 a.m. And we're going to go over a lot of different things, from not just occlusions, but beyond occlusions, talking about all the different potential things that could happen in your practices as you're jumping into the world of aesthetics.
Yeah, it's like everything from lasers, threads, chemical peels, dermal fillers, toxins, all of that. We're going to be talking about the possible adverse events that can happen, and then how to assess them and how to mitigate them and kind of help our patients heal and recover from things that happen. Everything has a risk. Everything has a risk. And I think if we know the most that we can possibly know going into it, then we can reduce some of that risk and some of the adverse event issues that might follow up. So, yeah,
so Beyond Occlusions, December 13th at 10 a.m. You can still sign up and register for that. Our AI webinar, which is December 16th, is going to be on Renuva. Very cool product, and we go over everything about Renuva that we know of. There's a new one on the block that maybe we'll play around with in the future, but Renuva has been around for how long is it?
Oh, years. Oh, probably. Years. Well, in the form that it's in now, that it's already pre-mixed, it's been at least 7 or 8 years. Yeah. But it was powder before that. So, yeah.
So December 16th at 6 p.m.
You want to learn how to grow your own fat? Listen to that webinar.
And then was it AI webinar for January 20th. This is at 5:30. This is going to be about cannulas. I think it sounds simple, but when Lori and I, and I'm sure Janelle and Trevor and Jasmine will attest to this, cannulas are not as easy as they seem to be made out to be. Yeah. I do lots of cannulas, more from the thread world. She uses it more from the actual injectable of fillers, but I think Cannulas are, when we train people on it, it seems like it's easy, yet when we're looking at them, we're like, oh my like, maybe you should learn, I don't know, it's the 3D spatial reasoning. It does not seem to go where they're thinking it's going. So, you know, we try and delve into the cannula aspect of it and teach as much as we can. But, you know, of course, that one is going to be an interesting webinar. And I think it's more near and dear to her heart to really see it, because she loves cannula so much. But even for her, sometimes training people on cannulas is a little bit hard.
It's like, I think most people have been taught to be too rough with cannulas and not be gentle. So this webinar is going to kind of help go through all the differences in cannulas. How are they different? What's the safety profile of them, and how can we be more safe using cannulas in our patients? So it's going to kind of approach all of those subjects. So I think it'll be a good webinar for you guys to see.
What's next?
And then we have our Foundations of Advanced Aesthetics course. It's coming up January 24th. I just had somebody DM me like, when's the next class? It's January 24th. That's the one that is any level can come. You can be very advanced. You can be beginner. But that's the one that you come and we kind of help you inject into your model. But if you have a lot of experience, then we will help you level up. You tell us, you know what, Lori, I need to learn cannulas under the eyes. I'll help you do that. You talk to Dr. Kwok. You're like, hey, Gideon, can I do, help me with my chin and needles on chin. He's going to help you with that. So we will help you level up and have a preceptor with you, a mentor with you while you do it, so you feel more comfortable doing it in your own clinic. So don't think this is a basic course. It is what you make it. You have probably 12 to 14 hours of didactic to complete, and you will learn more than you've ever known before going through that didactic. And then you have a year to rewatch that didactic. So it helps you for the next year. So it's nice.
And then moving forward into the rest, not the rest of 2026.
Going into 26,
we're moving into really down the road 2026. Ultrasound course in aesthetics will be April 25th for those of you guys that want to plan it out. It'll be with Janelle and Candice Jerry. It will be April 25th on 2026. You can sign up now for that. And then moving further into the year, August 15th to the 16th will be our Dissecting Aesthetics course, which will be our cadaver course. And I believe we are doing it back with Dr. Julie Woodward, who was really, really amazing. I actually really enjoyed her dissecting class.
Yep. Yeah, so she's phenomenal. She's out of Duke University. She's super smart and very good. Yeah.
I think that's it for
I know we have so many things coming up, but we thought we'd give you a little. We have people already signed up for these courses, so and that's deep into 26. So it's going to kind of fill up fast. So if you want to sign up for it,
plan ahead.
Don't lose out on your spot, because a lot of these, especially dissecting, the ultrasound and dissecting, both of them, the cadaver courses and ultrasound, it's limited hands-on because we want to make sure everybody has a great experience and it's very intimate. So that's why those are a little bit, we put those out further.
All right. And then, of course, don't forget our mentorship programs. I mean, we do have our levels of mentorship program. Lots and lots of videos, webinars that you have access to. So if you have questions, reach out to our team, or just jump on our website and look at the different levels. Founders levels, you actually get to mentor with us. We are jumping on a call with them after this call. And then it's the insiders level, and then I forgot the basic level. What is that called?
Insiders, founders, insiders, and there's 3 levels to our mentorship program. Founders is we love the founders, because you get like 450 educational videos. You get all the webinars for free. They're usually $200. You get discount on all the classes. It's like crazy. You get we open the courses like aesthetics, a lot of these courses that have a limited number, we open them first to our founders. So it's a really, really good level tier to have. What is the first level? Okay, well, there's 3 levels. We just show up, you guys. I'm sorry. All right.
All right, so we can now jump into our actual topic. I think this is a very fun topic, and just to get, all of the working minds together, we brought a amazing panel of practitioners. We have Janelle Ocampo, who has been doing this just as long as we have.
Yes.
And actually is part of our KOL team here at the Aesthetic Immersion. We have
Hi, Janelle.
Jasmine.
Hi.
Jasmine's actually her daughter. Actually, I think I met you a long time ago when I started training back then.
Yeah.
And then we have Trevor, who's from Las Vegas. Thanks, and he's also part of our KO team here at the Aesthetic Immersion.
Yeah. Thank you guys for having us.
Thank you for being here, you guys. We appreciate it.
So,
it's a privilege.
So we kind of want to talk about, this is going to be kind of a relaxed atmosphere tonight. We want to just let everybody listen. And those of you that are watching from home or your cars or wherever you're watching from, feel free to type questions in, because we're going to be watching our TV here and we can see questions that you have. And one of us, I'm sure, can answer your question. Or if you have an interesting case that's happened, feel free to kind of let us know what it was. But we're kind of just going to explain maybe some adverse event that's happened in our aesthetic careers that has kind of stuck in our mind, and why it occurred, and maybe how the assessment was, how it was treated. And it's not something that we have to do. A lot of them are sometimes sent to us from someone else too, but it's good that we learn from each other and we understand the potential of issues that can be out there. And then when we share that, it helps us all be better. It helps us all understand some of the risks and benefits and things that we can do.
yeah. But first off, why don't we have you guys introduce yourselves?
I love
how
it.
long you guys have been in the industry, because you guys have a lot of credibility behind your guys' names. Who wants to go first? Janelle, go
Janelle,
first.
go ahead.
Sure. I am Janelle Ocampo. I have a doctorate in nursing and I'm a nurse practitioner and have been in aesthetics almost 21 years now. Had a practice and sold that a couple years ago, and I've spent most of my time teaching since then. And so thank you for having me. It's been such a privilege. And but I've also been teaching along, practicing for I don't know, 12 to 14 years now.
Amazing.
Yeah, it's been a little while.
Yeah.
Started in the collagen days.
Right.
Wow.
Yeah.
back
Walked in the snow
then.
5 miles to school every day.
Those were the days.
I love it.
Yeah.
Sure.
Yeah.
Jasmine.
Hi everyone, I'm Jasmine Carrasco. I am a nurse practitioner and I started working with my mom back in 2013. I became licensed and started performing all of the procedures in 2018, and I have a love for the literature behind adverse events. So I'm super excited to be here. Thank you.
Thank you, Jasmine. Thank you.
And last but not least,
And
Trevor.
Trevor.
Hey guys, so Trevor Larson out of Las Vegas. I have my practice, True Beauty by Trevor. We had just passed 4 years in November, so really amazing.
Hey.
Emergency room, yes, emergency room background, ICU, did a little flight nursing, been injecting since 2010. Man, I think I've learned the most by my own mistakes. So I probably have a lot to talk about. But yeah, so
Perfect.
thank you guys for letting us be a part of this. I can't tell you how much Aesthetic Immersion has been a part of like my growth. I remember Lori, you helped training me through the process, all these things years ago. Gideon working with you and just working with all you amazing people. It's so great. So it's just meeting of the minds. And I love the community you guys build. You know, this community is something special, and we need each other, because right now our industry needs us. They need groups, they need team approach, and we need to do the right thing. So I'm just excited to be a part of this and really hope maneuver some of the things that because I think the best way to learn is learn from other people's mistakes and not your own. So I'll give you all the information.
Yes,
Right?
Yeah.
we hope.
For
I think
sure.
the operative
Yes.
word there is learn. Like if
Yes.
you don't learn from your mistake or somebody else's mistake, then you're just going to repeat it.
Yes.
So if we figure out
Yes.
how something happened, maybe we can think in the back of our mind of how to avoid that next time. And that's where we remember that.
Yeah.
We remember that. So that's where we really, really learn. It teaches us a lesson.
So
It is.
ju-
And it's the community.
It is. But just to put it out there, I think vascular occlusions is one of those things everybody fears. I mean, when I go training now, everyone's like, vascular occlusion area. I'm like, everywhere can be a vascular occlusion. But just from the 5 of us, I mean, how many vascular occlusions have you personally had in your own practice or seen? Just because, I mean, I think it's something we talk about as like this big thing that happens. It somehow seems to happen all the time. And, Janelle, you've been practicing just as long as I have. And, I personally, just to get started, probably have seen it once, maybe twice. There was a nose that I thought was, I just decided to dissolve it. But that was my Asian client being obnoxious as all Asian clients can be. But literally there was one that I really, and I can go over why that happened on my patient. And that was probably, what was that? That was probably 2018, 19, 2017. Yeah, it was probably decades into my career before I got my first real, what I consider vascular occlusion. And before that, when I started in 2004, I mean, we didn't know anything about vascular occlusions. So, I mean, I was injecting radius in noses. I mean, I think I did over 1,000 of them in noses because that was what my Asians wanted. And so, knock on wood, nothing happened to my patients. But, these are the things that I look back as like, ooh, didn't get a vascular occlusion on that. And those are the dangerous areas that we talk about. And maybe that's the reason why I'm still a little bit more cowboy-ish, according to Lori. I'm okay doing certain areas and injecting still certain areas.
Wait, where's that thing?
But, but I mean, for me, I would probably say one, maybe I could say two out of the 21 years I've been practicing. Lori?
I've been injecting 18 and a half years, and I've had no vascular occlusions. I've had one that was a spasm that went away pretty quickly within about 5 minutes or so. So no vascular occlusion. The spasm scared me enough, though. Yeah.
Any of you guys?
Yeah. I have had a couple that I've been able to clear really quick, but besides that, an additional 2. So if I'm counting all of those, that would be 4 in almost 21 years.
Yeah, that's not much.
So I've had 2. I had 2 they were pretty decent. That dang paraform. And I say, Gideon, this is why I cannula this area now, because I hit 2 strikes. I don't need the third one to get me out.
Yeah.
So yeah, I've had 2. I had a questionable one on lip that I'd love to talk about tonight because I think it will help mitigate some of these. I don't think it was occlusion. I do think it was a spasm, and I'll go into that as we get talking. But yeah, so I've had 2 solid, 2, and it probably came from some ignorance too. So once again, I'll talk more about that. But I think it's how we can mitigate them before they happen, right? Little rush, little busy. You do what the patient tells you. I think that's what happened with you, Gideon.
Yeah.
And this is where we get, right? So yeah.
Yeah. Jasmine, the newbie.
And yes, I've probably had at least 3 or 4 in the 8 years that I've been injecting. The 2 prominent were, one was a pure form with needle, and cannula ever since in the pure form, and a jawline or a chin. Those occlusions can be fun and have a really particular presentation. Any other occlusions have been cleared pretty instantly, and I don't think they were bruises.
Yeah, sure.
Okay,
sure.
So you can see, and between all of us, we've injected tens of thousands of times. And you can see it does not happen on a daily basis. It's something to be aware of. You have to be aware of it. It's like a code blue in the hospital. I think code blues happen more often than a vascular occlusion.
I think so too.
So,
for sure.
I mean, I remember going to the hospital when I was first a resident. I was like, oh shit, that's the one thing I don't want to deal with. And the first couple of weeks is like code blue after code blue after code blue, and we're part of the code blue team, so you just get over it after a while. But I think it's something that we can maybe talk about. Maybe Trevor, let's talk to you. Maybe you could talk a little bit about your lip and stuff like that, and things with regards to that.
Perfect. Well, one of the paraforms, it was, and this is, and if I go on a rant, please slow me down. But, the one thing is aspiration, right? And I think when this occlusion happened, it was me kind of like convincing myself, oh, I aspirate, everything's good. So what I'm getting out of this is if you're going to aspirate, be very purposeful. I think I I think once we inject and we aspirate, we're like, oh, it looks good. Did I take the time to aspirate? Did I keep the needle steady? Was I in a rush with this patient? I was, so I was kind of rushing. I was like, oh, it's good, pushed it. I even questioned it because it was sluggish to come back with, the CMS and cap refill and all that. So I told the patient, I'm like, you know what? I don't think this is it, but I want you to text me later and tell me how it is. And she texted me and it was worse. And it ended up occluding all the way up through here to the glabella. We flushed it out numerous times with Hylenex. It was really like surrendering myself to the patient and saying, hey, this is a complication. We need to face it. I'm here to support you. I got my plastic surgeon on the line. It was about the partnership of how we handled this. And I tell you, it woke me up to a lot of things because the people I may not have thought had been in my corner, they were. And this is where like community over competition. You run into complications like this and you think the people that aren't quite your friends, they're the ones that will be your friends. And this is why I really think community is important. So that one it cleared up. It actually, I think it took some time and she did have some skin changes and, not necessarily sloughing, but it was something that had to heal and it came all the way up her nose to the glabellar complex, did a little down the tip. So it was damaging enough to cause, some blanching, redness. She did heal slightly, but it wasn't like full necrotic, tissue, so to speak. So I do think like I jumped on it that night. We started flushing it. I do think there was still some peripheral, occlusion that probably happened coming to the glabella and the tip of the nose, which we just needed time. The challenge with this patient, she already had bad skin too. So it was kind of like, it was hard to like assess her skin because she kind of had some acneic scars and stuff to that extent. So once again, it's just how I evaluated my patient beforehand too, right? Yeah. Was her skin able to be assessed in a way that obviously she didn't have any like rupture or breakouts currently, but it was just her skin was hard to judge too. So that one cleared out, flushed with some Hylenex. It was good. The one I do want to talk about is that lip, So the lip one was interesting. The patient was nervous and anxious. So what happens when you're nervous and anxious? Blood pressure was probably low, right? So as I started injecting her bottom lip, she would already kind of like wanted to pass out before, and I kind of got her back around. But what I didn't realize is her blood pressure was low. So after injected, I would pinch the area to massage it, and it was cap refill is less than 3 seconds. And I was just like, there is no way there's an occlusion here, but we have to do the right thing, right? So it ended up being on the lower lip. I ended up reversing it. It didn't take a lot. And it pinked up right away. But as it started pinking up and I reversed it, she started to get good color in her system too. So the moral of the story is I do think she kind of vasovagal. I think she had some spasms. And I just think her blood pressure was so low that her lip looked pale, and it probably was the difference of was this an occlusion or just like low blood pressure and vasovagal.
But she had a good capillary refill the whole time?
She did prior. And then as she got a little lightheaded again, that started blanching. So I think it was really when she was getting faint and she was nervous and anxious that it caused because she just wasn't getting good blood return because her blood pressure had dropped. So I hope that I explained that correctly. So everything was good until her blood pressure dropped and she got lightheaded. So what I learned through that complication or that situation was always make sure your patients are in a good state. They have good blood sugar, they've eaten, they've done all the things, because her keep wanting to pass out and being flushed in her face, probably as I looked back on it, I was like, she probably wasn't getting good blood return anyways because she was flushed. So I dissolved it. It was fine. I actually think the dissolving didn't matter because when she got the blood return back and she was looking good again, I think she had come back around. You know what I mean? So questionable occlusion. I think it more taught me how to be aware of like the patient, right? And like their state, if they're pale and white and it looked like a ghost, all that blood is shunted to their midline and their peripherals are kind of bad. So I think that's where I questioned the complication on the lip.
Yeah.
So
that's going to change all of that. They're going to be very peripherally vasoconstricted,
100%.
So I mean, like that's where you lay them down, throw their feet up, and wait till they pink up, and then they wake up.
Yeah.
Sometimes you can inject and lay them down. They're not going to vasovagal on you laying down.
Exactly. So that was the thing. Just taking the time, being patient. If the patient's not feeling good, don't inject them. Don't try to get that one more poke. Exactly. So.
Yeah, absolutely.
This is the real world, it's
real world.
It's not a perfect scenario every time, which is, I guess justification for another argument of Lori's of having that foundational background before going into aesthetics so you can properly assess your patient, right? She's like, yes, that.
Yes, queen. You know, these people that want to go through nursing school and straight into aesthetics, it scares me. It scares me because we need to build that gut instinct. We need to build the assessment skills so that we can really do right by our patients. And what if I would say 90%, no more than that, 95% of people who watch a vasovagal, when I stop the whole procedure and I lay the patient down, I go, okay, what are we seeing here? What are we seeing here? You know, does the patient need a Coca-Cola? Do they need a cookie? Do they need ice? And I go through a vasovagal, and the majority of people, rarely ever does somebody really understand what a vasovagal is and what the pathophysiology is behind that, that it's just simply the blood pressure bottoming out. It's not sugar, it's not glucose, it's not, it's just the heart rate drops suddenly, cardiac output drops, and they faint. So if you put them down and get blood back to their brain, they're fine. So as long as we understand that, but I use that as a learning tool frequently, but most people don't understand the mechanism behind that. And I think a lot of that comes from, we work in primary care and acute care, and we see things like this all the time in ER and ICU, and we see stuff. So we develop that really holistic type of knowledge with our patients so we can really kind of treat them in any given situation. I think it's really important to have that experience. Knock on wood, please go to acute care before you go to aesthetics. Yeah.
Absolutely.
Well, it's a good argument on why that is helpful. I understand both sides of it, not wanting to have to work a couple years in a hospital. It takes time to acquire those skills.
It does. Yeah. And you know what? When I have people that they're like, nope, I don't want to do hospital care. I said, okay, you know what? Just work a couple days in the hospital and work a couple days in aesthetics. Just do that for a couple years. Just get your feet into an area that will help you with assessment skills. I think just work both part-time. You know, you can glean a lot from just watching and listening and doing. I think it's super important.
Yeah. Absolutely. Absolutely.
Yeah. Interesting. So, you know what I'm hearing from Trevor too is what I want everybody to pick up on is that he knew what to look for.
Yeah.
So the majority of a vascular event is it's going to happen eventually. You need to know what to look for. What are the signs? What do you look for? We look for capillary refill. We look for discomfort. Might not be any discomfort because
lidocaine.
Our fillers have lidocaine. So don't look for pain as an indicator, but look for the skin signs, the skin changes. And then if you know where your vessels flow, you know where downriver is, so you have an idea of where things might go, given whatever choke vessels might be working. But
and it may not happen right away.
So it's kind of interesting. It's like, I think we're still learning about it. We're still trying to figure out. I think some is intravascular, some might be extravascular.
But isn't it? Don't they say that the hyaluronidase actually, and you add some lidocaine, you actually do create some vasodilatation.
Absolutely, and
that's enough because at the end of the day, if you're blocking those end arteries that now or the capillaries is really where it is, you're acting at the capillary beds. You vasodilate that enough that it floats into the actual other side, the venous side. That's all you needed to do. I mean, it's a blockage whether you dissolve out a product or you actually open up the blood vessel enough that it floats to the other side. Once it floats to the other side, it's open ocean. You could care less at that point in time. By that time, all you're trying to do is open up the blood vessels so it passes on to the venous aspect of it.
And hyaluronidase in and of itself is a vasodilator, and lidocaine, plain lidocaine, is a vasodilator. So mixing those both together to flood the area is great. Just layer the area, but it can give you a false sense of I fixed it. Because you have that temporary vasodilatation, your capillary refill can come back and be great.
Yep.
Do not let them walk away. You have to see them that next day.
Yes.
You make sure you follow up with them because within about 20 minutes, that effect's going to go away and they might have a slow capillary refill again.
Right.
So that's kind of a false sense of I fixed it. Make sure you follow up with them, and even if they just sit in your office for an hour and you just recheck their capillary refill, That's what I highly suggest.
And there may be something to doing your vasodilators. I think that's why people wanted to put on Viagra and stuff like that. But I mean, you even think from the wellness world, there's nitric oxides out there that you could actually we should have those in our clinics. Probably you pop a couple of nitric oxide pills right away, get the NO up, vasodilate the blood vessels. That may be part of a protocol that we should probably add into.
Or nitrous. Like when I get issues that come into me, I'll have them use the Pronox. I'll have them breathe the nitrous because it's beautiful vasodilatation. Why not? Yeah, it's awesome.
So, all these things, I mean, at the end of the day, if you really think about it, to me, I think it really has to be something you got it into a blood vessel and it literally is intravascular. It's hard for me to believe that you get these vasospasms that are causing enough of that damage to create that type of a thing.
Yes, and yes. And when I talked to Leonie, she said a vasospasm can occur for 21 days.
Like how, though?
So on the studies that they've done, and she's seen that these vasospasms can lead to ischemia and necrosis if you don't get that cycle stopped and you get something in there to vasodilate it and reduce that spasm. So interesting, because I never dreamed the vasospasm could be like mine was like gone in 5 minutes. I never dreamed that it could be 21 days. But she's
it's hard to believe because a vasospasm would tell you that it's a muscular structure, which means it requires oxygen, which if you have no blood flow, you have no oxygen. So how do you sustain a spasm? Right? If you have no oxygen flow, I mean, how do you have a spasm?
Well, but you're not actually reducing oxygen to the muscle, to the artery wall itself. It's to what's being fed off that artery. So I don't think it's to that artery wall itself. That's such a good question, though.
I mean, all of this goes back to oxygen flow. That's the reason why your tissue dies, right? When you get into the pathophys, it's oxygen. How do you get oxygen there? If you're vasospasming, that requires the muscle there to use up the oxygen to actually create contractions.
Yeah.
And if you have very little oxygen, you're not going to sustain a vasospasm.
This is so interesting. I love this. Janelle, what were you going to say?
Yeah. I also think that most of these events are caused by an intravascular blockage. But I do think that vasospasms are a factor. And I wonder if sometimes we have reversed the hyaluronic acid, but there is vasospasm remaining, even if all the hyaluronic acid is reversed. It's hard to say. I have seen different, I started doing ultrasound several years ago, and so I've seen a number of cases, and I haven't been able to identify the occlusion every time. I've seen a limited number of cases. I think maybe somewhere around 6 now or something like that under ultrasound, and several of them I was able, maybe 1 or 2 more, but several of them I was able to identify exactly where the flow stopped. Right. Exactly.
Yeah.
But there are other ones where, yes, I couldn't identify it, and we just, guessed or looked for these silent areas. I think it's the same thing as kind of blind injecting, in all honesty. And I know that Hylenex causes vasodilation, and so does lidocaine. So oftentimes I'll inject lidocaine first, but I'm still stuck on the needle theory because I am concerned that using a cannula may, if I don't get into the artery with a needle to reverse the hyaluronic acid, is enough Hylenex or hyaluronidase getting into the artery? Is it penetrating it very well, right? So,
yeah. But I think that goes into maybe how much of it is the blockage. If you're talking probably in arteries where they're particulate and it's tiny little things, you just need to vasodilate it enough that it flows to the other side. If it is a bigger blockage of a bigger root, then yes, you do need to get enough Hylenex into that blood vessel to probably try and mobilize it, and that will actually shake it up, that maybe you will actually end up with even more propagation of particulate matter going downstream and blocking even more. And that's something you have to think about when you have a bigger maybe root blockage, is if you dissolve it, you may have like scatter shots of hyaluronic acid that go downstream and keep blocking things up, and you may be on this fight until you're able to pass that into the venous structures on the aspect of it.
I think of all the difference. I get sent a lot of complications, and usually they're 3 to 7 days post because they haven't been able to treat them or they haven't assessed them appropriately. But out of all of the ones I've been sent, I've never once had to cannulate an artery to put hyaluronidase in there to get them out of trouble. Yeah. But it's not that I wouldn't. Like if I thought it was an emboli, and I would look at the downflow of that vessel and go, okay, this is blocking everything down the road. I've got to try cannulating the facial artery or something. I would do it. I would try it.
It's really hard. It is not easy. It is so hard. I'm going to tell you. Yeah. And I was a sonographer in a hospital, and I did guidance for biopsies, all the time. But now we're like on the face in the angular artery like this, right, trying to cannulate it. It's really, really hard. I mean, even facial artery here is hard to cannulate. And this is a much easier area than on the side of the nose.
Yeah.
That is not easy to do.
No.
Yeah.
Definitely not.
Yeah.
And I and the big question too, as you're talking about intra, out, external, I mean, what do you think of the compression, occlusions?
I don't think there is such thing as a compression.
A lot of people talk like that. That
was
a hard one to agree with. I don't know if
your face can swell like this,
yes,
eating allergies. I mean, how do you think it's going to compress? Like, I think certain
agree.
things, compartments maybe in here, you can compartmentalize it because it is very tight tissue.
Yeah.
But we typically talk about compartment syndromes more in the arms and the legs,
Extremities.
where there are compartments. I don't think we have compartments really in the face.
Actually, there's one that I did on my Instagram. It's a necrotic nose tip that you guys might have seen.
Mm-hmm. Yeah,
she was sent to me.
We'll never forget that image.
Right? She came to me, and I can't remember how she found me, but she came to me, and I think she was maybe 3 to 5 days post, and she had three rhinoplasties. The plastic surgeon who did her rhinoplasties did her nose with filler. It was pale in the office. They said, oh, it's just swollen. Let's just watch it for a while. She sat there in the office for 20 minutes, was discharged with a pale tip. She came back the next day. He had the nurse inject Hylenex. Patient left. It hurt worse. It was still pale, awful. She went back the next day. The doctor himself saw her. He injected Hylenex in the tip and antibiotics in the tip.
Yeah.
And that, I believe, because the patient left and within a couple hours it was black. I think that was a compartment syndrome because this is so not stretchy.
I get that.
And
for sure.
It was already compromised tissue. Mm-hmm. So just injecting a cc of liquid in there, notwithstanding antibiotics, into the tip, I think it just made it necrotic right away. Yeah. So I got her after that.
Yeah, so I think the tip is probably, I'll give it to you, maybe a compartment in the tip. But the rest of the face, I don't think that.
Yeah, I don't either.
I don't think there's such a thing as compartment syndrome.
I agree.
Yeah.
Yeah.
But.
Well, going to your point, I think, and anyone listening, and as I go to training, I think we all see it. We are so in fear of occlusions. Like we gotta know how to handle them and be responsible on. But I mean, I think my practice alone injected 3,500 syringes and we had 0 complications last year. So I mean, the percentage is very small, but that doesn't mean you just got to know how to manage it, right? Like you said, Gideon, when you were on call, it's like, you hated code blues until you knew how to run them, and I think this whole conversation is just like, how do you identify? How do you communicate? And how do you work with your patient the best? And what are the steps to do this?
Honestly, one of the analogies I tell practitioners when I train them is like, please do not focus on vascular occlusions. That's like telling you are going to crash your car. And so every time you get in your car, you're watching out for the accident that you're going to get into instead of actually paying attention to what you're supposed to do, which is actually inject what you're supposed to do and watch your needles and stuff like that. But people are like, oh my God, occlusion. Well, that hesitation literally will cause you to move your needle in the wrong way. I think this is why I'm still a big fan of needle injections. I'll put it out there. I think it's more precise. Blah, blah, blah. I think it's just people don't know how to use a needle properly. I mean, I really, really think that people don't know how to use it. I will tell you, majority of those piriforms, I think it's because when you're aspirating or you're injecting, I watch people, and you both and I see it. When you start to inject, you pull up on the syringe as you push in, and you end up bobbing up and down. Because if you were on the bone, your blood vessel should never be on the bone. If it were on a bone, you would have a notch. The blood vessel, a bone is a living tissue. With 120 milligrams of pressure constantly going through that blood vessel, you are going to create an antigonial notch. You're going to create a foramen. So there is no such thing in my world, theoretically, that there should be a blood vessel on the bone. Could it be close to the bone? Yes. Could you, if you go perpendicular with your needle, push that blood vessel onto the bone? Yes. That's why if you watch the way I inject, it's always at angles. I don't like to inject perpendicularly. I inject at angles, you displace tissue. I would probably say I don't remember the last time I've actually aspirated anything in a piriform. And I do aspirate. It's not that I don't aspirate, but I don't remember the last time I've actually aspirated blood.
I want to add that even though we're talking about occlusions and it's making me feel like, it's a part of our practice, and it's a very, very, very small part of our practice is managing occlusions. But early management almost always produces great outcomes anyways. So if you just know how to assess your patient, identify if and when it does happen, whether it's you or a coworker or a friend that you're helping, if you can get to that patient early and manage it, they almost always have great outcomes and then continue to come back to you as a patient for years to come, right? It's the ones that aren't managed that end up with, the poor outcomes.
Yeah. And just remember, it's urgent, not emergent.
Right.
So it's not something you have to freak out about. It's like a code. Yeah. Like we don't really freak out about codes. Like, okay, start CPR, let's get the ambu bag. Ambu got a milligram of atropine, let's give that. So like it's not what you see on TV. So you don't have to freak out. You're just like, okay, let me just sit and look at this. Let me just sit and see. Let me check capillary refill on both sides to see if they're even, to see you want to look at one side for the other. Is it over 3 seconds? Is it 5 or 6 seconds? Okay, let's put some more compresses on it. Let's give it a little massage. You have time. It's not something you've got to run around and worry about. So it's something that you can kind of really monitor, and if you need to give your Hylenex, then you do. And do you understand how to monitor that if it's something that you can dissolve? If it's a non-dissolvable filler, there's nothing you can do. So,
well, I know, like, okay. Well, we can argue that too. There's lots that we will do, and we'll pray, and
Okay.
We'll still throw the kitchen sink at it.
We still kind of do everything.
We will.
We do everything, but we know it's not. Some fillers aren't. You can't dissolve them or break them down like hyaluronic acid fillers. There's some that you can't. Right. So it's a different type of an issue.
I honestly think it has to do with more of the amount of product that gets into it, like the one that you're talking about. I would say it's the amount of product. And this is where cannulas can get dangerous, because that was done with a cannula. If you get a product and your cannula goes straight into a blood vessel, you're shooting all of it into a blood vessel. And that is the thing. This is why you're very specific about cannula usage is people need to know how to use cannulas. With a needle, you may have popped a little bit into it, but you're going to move the needle in and out up to a certain point. So you could potentially say if you get a vascular occlusion from a cannula, it could probably be a lot more dangerous than a vascular occlusion from a needle.
Intravascular emboli. I get that, because if you put enough force into something to pop through an artery to get into an artery with a cannula, which takes force, you can't get it out. You can't get the cannula out.
So all that product's going to go right into the bloodstream on that aspect of it. So, I think it has to do with the amounts of products and this is why we do talk about a little bit smaller aliquots, making sure you know where you're at on the aspect of it. Because if you are using one that, for say, does not dissolve away, can you break it down? Can you break it down enough that it passes through and you can vasodilate it, that you can pass it through? Because you could potentially, theoretically you can. I know Lori will argue differently, but I actually think you can. If you actually, I have a shockwave. If you take a shockwave and shockwave it, you can potentially break up your product and actually micronize it. Because like a radius, for example, it's 30 to 45 microns in size, right?
But the density of what's in there is different than, say, a Sculptra. That's just like a fine powder in water. So the quantity of those.
But that's the whole thing, is if you can shockwave it and break it apart, you're breaking it apart it flows down.
But the quantity is totally different.
But it comes down to how much you put in there. It's not the quantity. It's, did you put 0.5? Did you put 1 whole cc?
The quantity.
Yes, of it. Yes. The quantity of it. But
we have so much fun here.
The product itself is the one that I think you can. If you only put 1 into it as a blockage, you could potentially, with some of all of the kitchen sinks, break it down and pass it through.
Dilute it. You're thinking of just dilutional.
But all of it's dilutional. If you're saying that you're not able to get your Hylenex into an intravascular, what's to tell me that you actually broke down the hyaluronic acid that was intravascular?
Nothing.
Exactly.
Not unless you got it in the vessel.
So this is the whole argument. If you have an HA in a blood vessel, or you have a calcium-based product in a vessel, and you're telling me your Hylenex doesn't move through the basement membrane of your blood vessel, is it really that you're breaking down? Is it just an artificial thing that we're just saying, oh, look, Hylenex breaks it down, and okay, HA breaks down? Or is it that we're actually vasodilating it and actually causing the openness of these products to pass through into the venous structure?
And two, one thing that people forget is that oftentimes, like in facial surgery, they ligate an artery. They'll ligate the artery. They will tie it off, and the face has no ischemia. So that's a whole
not fair,
right? So we could occlude a big vessel and not have ischemia. So then you go into, like, is it this bigger blanket of perforator vessels that's hitting the skin level at a little differently? So it's interesting. I think we have a lot to learn on it. Jasmine girl,
what's your research telling?
Tell us about what you've seen.
Oh, I have a case that I love talking about when it comes to adverse events, and it was my piriform case, and there were a lot of similar resemblances to Trevor's story, but I'd also like to highlight the gauge size of the needle that I used. It was a smaller needle, thinking that, okay, it's smaller, it's avoiding vessels, it's safer, and the patient had came in a little bit late and wanted her filler, and so I probably aspirated slightly shorter than I should have or could have, and that smaller gauge of the needle combined with less time may have influenced the factor, and as well as, like you mentioned, Gideon, pulling the syringe back with aspirating. That's also a really interesting factor. But I noticed ischemia pretty quickly. And with that case specifically, my sweet mother, Janelle, was able to come pretty quickly. And we used every vial of hyaluronidase that we had. And after the hyaluronidase, we definitely used over maybe 20 vials. I wish I could remember exact numbers. Yeah, we used.
What product was it? Do you remember the product?
It was Restylane Kiss. It was the Kiss needle.
So all that
Hylenex
was used before I came in. When I came in, we used 2 vials.
Okay.
Yeah.
I honestly think that you probably don't need to use that much in the initial stages. Mine was a 0.1 in here of refine, 0.1, 0.15, and it ended up going probably mid nose all the way out through this area. I probably used a total of 6 to completely reverse it.
The difference.
Was that your first case, Jasmine? I can't remember. Was that your first or your second? I know you've had the 2.
It was my major.
Okay.
And then I loved that lidocaine.
She did have discoloration from here to here.
Oh, wow. Okay. So how much do you think you used?
It was either 0.05 or 0.1, no more than 0.1. Never would I use more than 0.1. I wish I could remember exactly. It was either in 2020 or 2021. But
we had just bought an handheld ultrasound device, a V-scan, and I hadn't touched an ultrasound in years. And this occlusion happened. And so Jazz opened the box for me, and I set it down after never scanning a face before, basically. And I found it.
Oh my gosh.
Yeah,
Queen.
because it was just obvious.
That's
though.
Good.
It was it was on the side of her nose, the angular artery. And
wow.
Go ahead. You can continue with your story.
The lidocaine made a really big difference in that case that I remember. Janelle saw the occlusion, and I mean, we'd used so much Hylenex and had seen a difference in mottling up the forehead, and that could have been product breaking down or vasospasm. We don't know. I love talking about the theories of vasospasm and intra-arterial or outside of the vessel. But after the lidocaine, that made a big difference, of course, in Hylenex as well.
Right.
Yeah.
Patient healed well, no issues.
When you look at those symptoms here to here, how could that not be intravascular? Right. So I look at that and go,
we saw turbulence in the angular artery, and then it stopped.
Yeah.
It was one of those obvious ones.
Okay.
Did you cannulate the facial artery?
Well, as soon as I was able to identify it, because the device hadn't been like fully charged and it took me some time to even find it, it died, but I was in the exact spot. And so I went in with the Hylenex and injected the exact spot right when it died. And then she went in and flushed the area with lidocaine. And I was like on the phone, calling everybody. I called Leonie. And by the way, she said, send me the photos, I will help. But just so you know, when I had walked away because I was really worried because of the amount of discoloration that we saw across her face. And I saw it and I knew it was a big one. And I thought, I'm not going to be able to cannulate this when this recharges. And I had stepped away, and I wanted to take her to Hoag for someone to help me. I'm like, they've got an ultrasound there. I want to take her to Hoag again. And someone's got to help me cannulate this. It cleared. So it was just from the blind injecting after the ultrasound died.
Awesome.
Because Jasmine walked in and reassessed her a couple minutes later when I was on the phone calling our medical director, calling Leonie, calling Dr. Yolen. I was like, what do I do? They're like, you know what to do. I'm like, no, tell me something else. I want to hear something else.
and I'm sure Leonie was telling you it was all perforator vessel vasospasm. And you're like, it's following a line.
It cleared so quick. I had just started contacting, and then people were calling me back. Just who can I dial? I need somebody, because it was such quick discoloration across her face because it was such a big occlusion, and I could see it, and I just felt a little helpless because I was so new to ultrasound in that moment. But
so the other thing that is in the back of my mind, okay, piriform is a fourth leading cause for blindness. We know there's a direct track to retrobulbar circulation. So in my mind, I'm like, okay, so I cannulate an artery, I'm pushing Hylenex in there, and am I pushing something where I don't want it to go? I mean, that's
exactly what she said to me when we were there. She's like, you don't think that'll push it up further, will you? And I was like, I think, did we even put pressure?
Yeah.
I don't remember.
We did.
Because we were having the conversation in that moment, and that's what she was saying to me when I had driven in to assist her. She was like, do you think that could actually push it up more?
Yeah. And that's exactly like when we were dealing with a pretty bad occlusion with Kaha in the STA. Do we want to cannulate that vessel and flood it, because it's just going to push it downstream? And what's downstream that could be dangerous? So there's a lot of things running in our minds sometimes. It's tough. Yeah.
For sure.
Thankfully, that was my last occlusion.
Yes.
Back then, I was done with occlusions after that.
But you know what?
That was the biggest one I've ever seen. That was a very unusual one.
That would not. Yeah. That'll never happen again. But but assessing it and knowing, like, okay, I've got something here I need to treat, or if I can't, I call in the troops. And if if Janelle, like, okay, Janelle, this is bigger than what I've seen before. My ultrasound took a dump. I'm going to call in my troops. And what's so nice is we all are connected in this industry, specialty, I should say. We're all connected. And when something like this happens, we are all there for the patient. We don't care what product, we don't care about who injected it. We are there to help treat that patient. And that's what's so important about it. So don't be afraid to call in the troops and ask people that have more experience than you or have a device than you don't to come help. They really will help with that patient. We're there for the patients.
Real quick, there is a question asking what is in our occlusion kits.
That's it. We have a safety series, and I think it's in our safety series. That's free. Our safety series is free.
Perfect.
And I think we have that in there. But here's what's funny. I have treated many occlusions. I've never once pulled the occlusion kit off my shelf.
Yeah.
Hylenex, lidocaine.
Hylenex and lidocaine is kind of like
needles.
Yeah.
Aspirin, maybe.
There's aspirin in it.
Yeah. Instant hot packs.
I've got a retrobulbar cannula, which I'm going to throw away. We have different. Basically, the big thing is Hylenex, lidocaine, saline, or if you want to kind of dilute anything down. You want to warm compresses. And the big thing too is like if somebody does have ischemia and you've done a lot with them and you're like, come back the next day, get them off to hyperbaric. Get them off to hyperbaric treatment. I think that has saved so many possible necrotic issues and really helped that perfusion in the skin. So find out where your local hyperbaric chamber is and get a relationship with them so that you can get them over to hyperbaric and maybe do 1 or 2 dives a day at least 2 ATA. Try to get at least 33 feet deep. That will help quite a bit. 1 or 2 a day has been tremendous, just in the survivability of tissue. And if it's an area and they don't, you kind of worry about an area being a little bit more ischemic, it's hanging in there, you can always get that machine called an EO2. It's an external transcutaneous oxygen. It's called EO2. And you put a patch on the patient's face. It's like a little gauze with a tegaderm. And then they wear a little fanny pack that's charged, and it puts 100% oxygen 24 hours a day onto that area. And it's beautiful for adverse events, for aesthetics. It's really used for diabetic wound ulcers. So it's awesome. And the company sends the machine to the patient's house. It's phenomenal.
Yeah. The thing with the list, I say, is like I have one on every inside of my door of every room. I think it's just like having preparation. So if something happens, your staff knows what to turn to and what to do. The kit, of course, if you have one in a fridge is great, but it's just knowing what you need to grab and what your accessibility is, because some people get a little crazy, when things happen. So it's like controlled chaos, right? Reference the occlusion kit, whatever you need for products. Yeah.
Perfect.
So.
And what Lori said, it's urgent, not emergent. As long as you have the supplies and know where to access them, you've got time, you can breathe a little and, take care of it.
And if you don't have ultrasound, try to have at least 24 vials of Hylenex on hand. I know that's a lot, but that's your insurance policy. I always have at least 24 vials. Now that I have ultrasound, I've really never used more than a couple. So I might have 12 or 16 on hand. but yeah, have plenty of Hylenex on hand, and know the different clinics around you that you can call them and ask them for some if you need it. So it's good. All right, we are over, huh?
We are over.
We're over time.
The team's like,
oh
come on, move it.
This has been good, you guys.
Thank you so much, guys. Thank you. It's December 13th, guys, Beyond Occlusions. If you want to hear more talks about not just vascular occlusions, but all the other things.
Right,
that
we didn't even get into
all of
lasers.
That. Definitely join. I think they said you get $200 off if you register. So December 13th at 10 a.m. Pacific time is going to be the virtual event. And then, let's see, January 6th, I'm probably be out of town. So Lori's going to talk about how nitrous almost killed her.
Oh.
So that will be January 6th at 5 p.m. Other than that, what else?
I don't know. We've got good stuff.
That's it.
Yeah.
This will go on our podcast on YouTube in a week or two. Other than that,
we have our beginner course. If you have anybody who's still working in the hospital or anybody just starting out in aesthetics, we have our FFI course, which is the Foundations for Aesthetic Injectors. And that's going to be February 21st. February 21st. That's live here, and you get to kind of play around with jelly and see how it all works. So you can tell people that that class is going to be the 21st here in Brea, California, and they can sign up for that.
Awesome. Well,
perfect.
Other than that, Merry Christmas, guys.
I know. Merry
Happy
Christmas.
New Year's.
We will see you.
We'll see
Thanks
you guys
for
in the
having
new year.
me.
Thanks
Thank
for
you,
joining
guys.
you guys. Thank you, team. Thank you.
Bye.
Thank you.
Bye. Thank you for watching.
And don't forget to like this video and subscribe to the Aesthetic Immersion channel.
And check out all the other videos we have to offer.